Thank you very much, madam. Good evening, all of you. I am very glad that this topic has been included in this conference, and many a times I have seen such topics get omitted. I am very glad to see Professor Rohini Handa also in the audience in front, very dear friend, a very senior colleague at AIMS earlier. So, may I have the first slide, or should I change from here myself? So I bring greetings from AIMS New Delhi to all of you, and as Madam has already conveyed, I am serving at present as Professor and Head, Department of Physical Medicine and Rehabilitation. And we have a number of patients referred to us from the Department of Rheumatology, Department of Orthopedics, and many more come walking into our department for seeking consultation. The topic that is assigned to me is support stories, the right fit for orthotic appliances. And I was also suggested that I should try and cover some important questions which are often in the minds of physicians or rheumatologists, but paucity of time will not allow very detailed discussions or long discussions. But we can continue the discussion during other breaks. Now, you are all aware of what orthotics are. I will not go into the basic definition. You are all prescribing orthotic appliances. What I want to emphasize is that management of medical conditions which are chronic in nature, such as arthritis, is essentially a multidisciplinary team approach. And that team consists of specialists of various kinds. But if they are all having the patient with arthritis at the center of their deliberations and discussions, then we can do a lot for the patient. Otherwise, I have very often seen that if you have a hammer in your hand as the only tool, then every problem appears to be a nail. So if you are an orthopedic surgeon, you want to do osteotomy, or you want to replace the joint, you want to aspirate the joint. If you are a physical therapist, that you claim that you can set the joint straight by exercises, by heat treatments and all. And if you are a physician, you feel that you can cure the arthritis if the patient presents to you at a very early stage. All of these are right in their own way, but the truth is much more than that. The reality is our patients do not present very early, when perhaps we can do the best, when the process can be slowed down or to some extent reversed also. Many times we come across patients at a very late stage, especially the osteoarthritis of the knee joint. They come to us with grade 3 or grade 4. And that is when the chances of interventions by orthopedic procedures becomes higher. Although grade 1, 2, 3 can be managed through conservative means, but then for that the person's compliance has to be very good. And again, it has to be a team effort. Orthoses of all kinds are available in the market, and many a times these are available off the shelf. You don't need a prescription also. If you walk into a store and ask for an orthotic appliance, the person who is handling the shop will give it to you. He will not insist on a prescription. And the sad part is that most of the physicians need to be updated in terms of how to prescribe an appropriate orthosis in a proper way. We are learning, and I don't blame anybody. This is the general scenario. The majority of patients in primary and secondary healthcare delivery system centers do not know which anti-rheumatoid arthritis drugs to prescribe, when, how to monitor the side effects and all those things. So here I am not standing to blame anybody. We are all working in a particular environment which needs to be improved, and that is where such conferences play a very important role. When we are all sitting under one roof, we are learning from each other. Now, I want to sum up the entire gamut of rehabilitation principles and practices through this single slide. And if you go back with this in your mind, you will be doing much more for the patients whenever you come across. The most common alphabet in English language is E. and it is the fifth alphabet in the series of 26 English alphabets. So easy to remember by that. If you remember 5 E's, you can cover almost the entire gamut of rehabilitation practice. The first E is the most important E, that is evaluation. And as clinicians, we are all taught how to clinically evaluate the person, how to take a meticulous history, how to do a thorough physical examination. And based upon the information that we get out of history and the clinical examination, we can decide which investigations to recommend to the patient and how to interpret those investigations. If you spend maximum time in evaluation of the patient with arthritis, then the chances are that whatever you prescribe based on the findings of evaluation, you are more likely to succeed. The patient will be better off with that kind of thorough evaluation. Because subsequent follow-up visits, you will be spending less time on the patient. But many times in a busy OPD, I have seen the first evaluation is generally not thorough, or it is delegated to the junior doctor in the team. There is an ICF model of WHO, International Classification of Functioning, Disability and Health. And in rehabilitation field, we are using some of these terminologies more often, but I wish other specialists also start using that because it is a biopsychosocial model of disablement. It can explain many things which the person is suffering from. The second E is education of the person about the disease, about the drugs, its side effects, dosage, her role in the regular follow-up, what are the investigations, when are these to be done. Then the third E is exercises. They are of various kinds depending upon the stage at which the person presents. We normally begin, if the person is having acute symptoms, we give rest, apply ice, do the compression, elevation, and most importantly, isometric exercises instead of isotonic ones to begin with. But as the condition improves, we recommend isotonic exercises and ultimately graduating to the functional activities, because ultimately the person has to have the independence to perform the various functions expected. Then equipments play a very important role, and that is where the orthoses come into picture. They are a kind of equipments which serve many purposes, provide rest, decrease the progression of a deformity, reduce the swelling, etc. Then we often ignore the environment in which the person is functioning. So that is a very important E. So if we take care of these 5 E's, we can select the appropriate appliances, we can modify if the stage demands, and in the environment it is very important to remove the physical barriers such as the stairs and other things, and also remove the attitudinal barriers. In our society and in almost every society, persons with arthritis and disabilities have attitudinal issues that they have to face. The society is not very receptive. For the society in general, disability means inability. It is not so. With proper rehabilitation through a team approach, no person with disability, especially due to arthritis, can be ignored, and every person's functional performance can be improved, quality of life can be improved. Now, here I am advised to focus on 3 main areas of the body which are commonly affected with arthritis. And knee joints are very important joints, weight-bearing joints, which are most often affected with osteoarthritis. Spine is also another very important site affected with degenerative joint disease, and wrist and hands. And patients with involvement of some of these in combinations or alone present to us. And as I shared in the previous slide, based upon the evaluation, we decide whether the person requires heat treatment, whether the person requires any support, and if any exercise is required. Many times patients present to us from the rheumatology department where the investigations have already been done and medications have been prescribed. But we do have a look at that, and if the person is coming to us directly, we do prescribe certain medicines. The range of orthotic appliances, especially for the knee joint, is enormous. If you go to any store or if you search the Google, you will see many braces. But they are of 3 different types. Some of these are classified depending upon the design or the materials which are used. There is another way of classifying them, whether these are prophylactic in nature, whether these are offloading, or these are simple supporting sleeves. So depending upon the way one classifies, one can select. And in this you can see grossly there are two different types of designs. In one there is patellar opening and the material used is relatively softer. In the other diagram the orthotic appliance is more extensive with the side bars and a joint in between. This is another design of a knee orthosis. Basic purpose served by both is same. The difference is in the comfort and the weight and the part of the body where the pressure is relieved or applied. Most of these orthotic appliances work on the principle of 3-point pressure. If I express in the context of knee joint, there is 1 point of pressure in the thigh on the medial side. There is another point of pressure in the calf area on the medial side, and then there is an opposite side point at the knee level which is counterbalancing those forces. This is another hinged knee joint. Now, when there are so many types of knee orthosis, it becomes very important to compare the effectiveness of these, and that is where scientific studies are important, and some of the people have done the studies and they have published their results, and now we have some evidence to support or not support some of these appliances. Now this is a very important publication by American Academy of Orthopedic Surgeons, Management of Osteoarthritis of the Knee, Non-Arthroplasty Way of Managing. Now this is an evidence-based clinical practice guideline. It was adopted by the American Academy of Orthopedic Surgeons Board of Directors in August 2021. It has also been endorsed by American Physical Therapy Association and American Association of Hip and Knee Surgeons. So this is a very voluminous document, more than 125 pages, with a lot of details and the strength of evidence for some recommendations. So summary of the recommendations which is relevant to the topic of presentation today. It says lateral wedge insoles, these have been used very commonly. Lateral wedge insoles are not recommended for patients with knee osteoarthritis. That is the recommendation of this important document, and the strength of recommendation is strong. Evidence from 2 or more high quality studies with consistent findings for recommending for or against the intervention also requires no reason to downgrade from this framework. The other is canes. Canes could be used to improve the pain and function in patients with knee osteoarthritis. They relieve the load from the joint, and the common question is in which hand to hold the cane. It is normally on the contralateral side that you hold the cane. Or if both the joints are affected, then whichever is less severely affected. And the strength of recommendation is moderate. The other is braces. Brace treatment could be used to improve function, pain and quality of life in patients with knee osteoarthritis. And the strength of recommendation again is moderate. Earlier it was strong, but it has been in the recent recommendations slightly downgraded because good quality comparative studies were not so many. This is another Cochrane study report, braces and orthosis for treating osteoarthritis of the knee. This is a review, and in this they have concluded that evidence was inconclusive for the benefits of bracing for pain, stiffness, function and quality of life in the treatment of patients with medial compartment knee osteoarthritis. The optimal choice for an orthosis remains unclear and long-term implications are lacking. But in the short duration, many patients do report relief and benefit. But the selection has to be proper, the fitting has to be proper, and it has to be periodically reviewed and if necessary modified. The goals of orthosis should be patient specific and might include the following: provide pain and symptom relief, that is what the patients most often want. Improve positioning for functional tasks, stabilize a weak joint, realign a deformity in a joint so that its progression can be retarded and prevent unnecessary joint motions. Tips for a more comfortable orthosis should always be kept in mind, because if the orthosis is uncomfortable, it will not be complied with. And many times we have to pay attention to the material which is used to make the orthosis. This is especially relevant when we are considering the joints of the hands and wrists. Many a times patients with rheumatoid arthritis have also thinning of the skin and other issues related to vascularity. And we have to consider the position of the orthosis. Many times there may be carpal tunnel syndrome present. So how much dorsiflexion of the wrist has to be there in the splint? This is very important. Otherwise the pressure on the median nerve will be increased and the patient will present with worsening of tingling sensations. Then we have to also pay attention, because most of the patients with rheumatoid arthritis especially are female patients, they are young patients. So attention to the aesthetics, cosmesis and the weight is also very important. And fortunately we have now materials where there can be significant color match with the skin color of the individual. Coming to the end of my presentation, there are several publications, but one of these is comparison of the efficacy of laterally wedged insoles and bespoke on unloader knee orthosis in treating medial compartment. Knee osteoarthritis is generally beginning with medial compartment involvement. And many people have studied this more. But in this study also they concluded that there is not major difference between the wedged insoles and the unloader knee orthosis. Last 10 years, unloader or offloader knee orthosis are becoming very popular because of commercial reasons and aggressive propagation by. This is what they compared, the insole and the joint orthosis. The last two slides, this is a model that I was referring to earlier, and we need to be using this more and more in our understanding and recommendation for the patients. There is a health condition, in this case the arthritis. It has effects on the body function and body structures. Activities may be affected by the condition, and participation, involvement in the life situations. Many times we are more bothered about the swelling of the joint count, the degree of restriction of range of motion, etc. But ultimately, how much is the person restricted in terms of participation in society? That is very important. Is the person able to enjoy the family life? Is the person able to celebrate festivals? India is a land where every month there is 1 or 2 festivals. So if the person with arthritis is confined to home, not able to participate, then there are contextual factors in this model which are very important. These are environmental factors and personal factors. No patients with the same stage of arthritis are the same. So these contextual factors become very important in the overall understanding and impact. Disability is essentially experience of the individual. So no two individuals are alike, and that is why it is important. And this is the last slide. As I told earlier, that management in a comprehensive way of a person with arthritis is a teamwork. And in that team, there are many people which are very important to play their role. And I have colored with the red font 3 of them, but others are also very important. And the 3 include rheumatologists or physicians, which many of you are. Some orthopedic surgeons are also in this audience. They play a very important role, and physical medicine and rehabilitation experts. Nobody can claim to have the knowledge and skills essential for managing the person with arthritis single-handedly. So it is a teamwork, and the take-home message is, if you start the management early, for that the person has to present early, and for that there has to be raised level of awareness in the community and among the GPs. Team is not a word, it is an acronym. And most of the times I say that team means together everyone achieves more. So we are all, if we are all working in tandem with a particular goal, and that is centered around the person with arthritis, we can all contribute more, we can all achieve more. And no matter how advanced or the late stage of presentation, there is always hope. We can relieve the suffering of the person, we can try and improve the quality of life, if not the quantity of life. And what cannot be cured must be endured with support and hope. We want to see smile on the face of every person with arthritis, and that is the motto of rehabilitation practice. Thank you so much.